we're going to start with introductions, and then Melissa's here to give us the didactic today. And then you guys can ask any questions, or if you have any case thoughts or anything like that, just let us know. Melissa, do you mind to start introductions for us?
Sure. So Melissa Phillips, I'm a nurse practitioner. I've been in our endocrine clinic for 5 years. I did my training at Penn State University and also here at West Virginia University. And probably 70% of my practice is type 1, type 2 diabetes. Everything from about age 18 to 85 and pregnancy as well.
Perfect. Thank you so much. And then Leslie, do you want to introduce yourself?
Yes, ma'am. My name is Leslie, and I work at a nonprofit clinic in Virginia as a clinical pharmacist, and I just want some updates on anything diabetic related because we've got some studies coming down the pipeline with UVA, and anything I learn is good. Thank you.
Perfect. Thank you for joining us today. Mitra, do you want to introduce yourself?
Hey guys, I'm Mitra Motasham, and I'm Project Echo Coordinators. Thank you.
Perfect. And everybody, I'm Caitlin Ettinger. I'm one of the Project Echo Coordinators. As I said, I think we'll have a couple more people jumping on, but they'll just introduce themselves via the chat. And Melissa, I don't want to take up any extra time, so are you okay to get started and share your
Yes,
slide?
that'll be fine. So the topic is always pretty broad when we're discussing this, so trying to bring it down to what do we want to talk about and keep it simple, but hopefully not too simple. And I'm hoping this isn't actually too simple for the presentation as far as what goes on. So next slide is basal bolus insulins, and truly just going over, I don't have much on the slide. I'm going to kind of just verbally talk about how I utilize these drugs. Toujeo came out a few years ago. It is a basal insulin. Probably one of the most attractive parts of it is that it does have an onset that is at least 24 hours. So the top 2 insulins that I'll talk about are the ones that have the longest duration of action. And that's kind of what grabbed everybody on this insulin. And then also would be the concentration, 300 milligrams per milliliter concentration. I think it doesn't hit as much in primary care, but in our practice, we get a lot of patients that are on very large doses of insulin, and that's why they get sent to us, because primaries are sometimes a little bit leery about how much insulin can one person take. So that was also extremely attractive for it. So you get that. Then the syringe came out, and you were getting one unit titrations where you could just dial it up by 1 unit. And then actually Tresiba, the next drug I'll talk about, came out. And so a few years after that, then Toujeo had to come up with a more ability to give more insulin in a syringe, and they came out with what's called Toujeo Max. And basically that just allows you to go up by 2s instead of, and then there's obviously more insulin. It's a 3 millimeter syringe. They were also able, one thing that was nice in this Max is when you think of a bigger volume, they were able to keep the pen size the same, which makes it really nice. One of the big faux pas that I find when patients come to us is they end up getting dosed somehow with twice-a-day dosing, and I can tell you this is a big no-no on this drug. This drug should be daily dosed, and it should not be twice-a-day dosed really for any reason, because of the onset of action is in 6 hours, and the duration of action is actually 36 hours. So the other thing to teach patients, and the reason you're going to choose this drug, is for compliance purposes. So how many patients do we get that says, oh, I take my insulin at 10 o'clock at night? Well, sometimes midnight. Well, I wake up and I fell asleep and I didn't wake up till 2 in the morning, so I didn't know what to take. So this drug is good for that patient that doesn't know or doesn't take it consistently, because you won't have the issue of 24 hours and it's gone. So you will have a buildup of this drug basically, and that they can actually take it. I mean, you try not to teach them that they can take it anytime they want, because the more flexibility you give with patients, the more they kind of take off. And, you know, you said 2 hours, they do 4 hours. So I actually teach that this drug can be, the rule on the insert is that as long as it's given before 8 hours of the next dose, so say they take it at noon every day, as long as they're taking it by 4 a.m. before noon the next day, they actually could take the dose again. But that's a little bit extreme, I think, and very hard to teach patients. So I kind of tell them they have a 8-hour window to give the drug. So if they always give it at noon, they could give it at 8 a.m. so they can feel confident that they're going to be out for lunchtime today doing their errands. So instead of forgetting your insulin, why don't you take it at 9 a.m. and it's not going to affect their sugars over the next 24 hours by taking it 3 hours early. Also, the reverse is true. You can teach them, well, you were out longer than you expected, so as soon as you get home at 2 p.m., you can still take the drug. And it would be the same dose, and you don't have to worry about fluctuations in blood sugars. There is no peak with this. The longer half-life and the chemical makeup of it allows that security of being able to dose. And like I said, I just kind of use 8 hours, but the technical insert is as long as they dose it before 8 hours of the normal scheduled dose time, then you could still take the full dose. I hope that makes sense. So daily dosing, and then titrations. This is something I think may be helpful for some people. We don't have really providers on the phone call, so maybe not as important to discuss at this point, but you titrate it every 3 days. Because of the half-life being 24 to 36 hours, you can't increase the dose, or you should not increase the dose every day. So you shouldn't say, please increase by 1 unit every day for the next 5 days. You would actually have to do it every 3 to 4 days on this titration, and that has to do with the half-life, and I'll speak about that a little bit more towards the end of the presentation. But the issue, and the other strong issue with this drug that works very nicely for really type 1s, I feel like I see it more in my practice, and then the type 2s that are a little bit more sensitive, it helps a lot with variability. So you don't have the peaks and the valleys that you can see for their actions that they do during the day. It basically just kind of levels out the waveforms. And when you start to get CGMs in the use of these top 2 insulins, Toujeo and Tresiba, you'll see that these waveforms become a lot more stable and not so high and low. They also need to not be on short-acting insulin for you to be able to witness that type of waveform change, but it actually does. And I was looking for some pictures on that, and I could not find anything that was actually appropriate towards this. So Toujeo can have some insurance issues. Like most drugs, we don't get to deem it, but I do go after this drug. And if we go to the next slide, or this drug, Tresiba, and both of them are made, Novo and Lilly do these, so they are the top 2 drugs. But the utilization of Tresiba is very good through Medicare, so I tend to prescribe at this point a lot of Tresiba because it has better coverage, and Toujeo company would not be happy with me saying that, but it is kind of the truth that's going on, at least for this fiscal calendar of how Medicare is actually covering medications. So Tresiba does have a little bit better coverage right now for Medicare and Medicaid. But this drug is very similar. One thing that is a big difference is the onset. So naive patients getting started on these drugs, which can happen in primary care more often than me, because very few patients do I start on insulin. They normally come on at least a little low dose, but this actually has an onset in 1 hour, so don't have to wait as long. If you notice, Toujeo has 6 hours, so you just kind of have to tell the patient to be patient, but once they're on insulin, they don't really know, because you're switching from Lantus or Levemir to one of these drugs, and that option is not really as important. It's only in the naive patient. The duration of action for this one is actually longer. The talk is still within 8 hours, but I feel like this longer duration improves that stability of the waveform that I talked about, so less peaks and valleys, with insulins basically running short and not covering the whole 24-hour period of time. So this one's 38 to 42. Again, this is daily dosing. So please, please, please do not be dosing these twice a day. It's hard to get patients off twice a day dosing when we do this. So they also come in concentrations dependent upon the amount of insulin someone's taking. So Tresiba has the classic 100 concentration, which we're used to in Levemir and Lantus, but it also has a more concentrated form of 200 units per milliliter. Again, when you're doubling up the concentration, they're keeping the milliliters the same, so getting a lot more insulin in your pens, but the dispensement is obviously different. Unfortunately, you would think that you could just go from 100 unit to 200 unit and the insurance would just give it to you, but it needs a prior authorization. So make sure you're prepared for that whenever you switch it. It is something that has to be approved and sometimes can be a little bit of a headache. The smaller syringe, 100 units, only gives 80 units in an injection time. So anything over 80, please, please, please have patients take their needles out of their skin and inject the next 20 units. If they're on 100 units a day, crazy some of the things that you hear, but people will inject, keep the syringe into their skin, and then they'll sit there and redial it back up and then inject the next amount of syringe that they needed. So again, if they needed 80, they would inject, not remove the syringe, then dial it up to 20 to give themselves a whole 100 unit. That's bad for absorption, so it shouldn't be done like that. They need to pull out and do a separate injection, or move them to the 160 units syringe that has more units, and you can dial that one up to 100 and do it in one injection, and that's because it's 200 unit per ml and it's more concentrated. This drug, again, like Toujeo, can only be titrated every 3 to 4 days, and that has to do with the half-life. Next slide. Lantus and Basaglar, they're both insulin glargine, but those are the brand names for it. Their concentrations are 100 unit per ml. These, though, can be daily or twice a day dosed insulins. The recommendation that we tend to use here in our endocrine clinic is if they're over 80 units in one injection, then you would probably need to consider doing twice a day injections. This also should be done 12 hours apart. Teaching patients that this half-life, it has a duration of 12 hours. It has no peak, and it has no and it has 24 hours. So if you give your insulin at 8 in the morning, you should give it at 8 p.m. If you give it at 7, it should be 7 p.m. And the reason is if they give it at 8 p.m. and then they decide to give the next dose at midnight, it's not a 50-50 and you're not overlapping equally, and you will have a different change of your sugars because of the twice a day dosing. You're basically overlapping a little bit more or less for the period of hours when you don't twice a day dose 12 hours apart. So try to keep it with that. The nice thing about Lantus and Basaglar is that you can actually daily titrate that. I feel like most patients, it's difficult to get them to daily titrate because they get nervous about moving their insulin that fast. But again, the reason you can daily titrate is because the duration of action is only 12 hours. So that is the reason for that. Lantus and Basaglar are probably then my second. Toujeo, Tresiba, really insurance dictates which one I try to use. Lantus, Basaglar is my second line of choice. And again, it's mostly insurance dictated on which one we're able to use. Next one is Levemir. Levemir's been around forever. It's detemir insulin. It also should be twice a day dosing. So it really is not a 24-hour drug. It talks about the duration of action is 8 to 12 hours. That's from the package insert, 8 to 12 hours. So it does not last 24 hours. So if you are single dosing it and need to utilize it, even if they're only taking something like 10 units, I mean, it's hard to say you do 5 and 5, why can't you give it? And most of the time we don't, but just realize once you get to 20 or 30 units, you really should separate it out to 15 and 15 because of this duration of action. Again, making both doses equal. For some reason, I tend to see this a lot in Levemir coming from other providers, that their morning dose is 80 units and their nighttime dose is 30 units. It really should not be such a difference. This is a no peak or no true peak. Sometimes the duration of action is what causes that to happen a little bit. Also, you'll see some hypoglycemia overnight. So that's why we also tend to, but try to keep it a little bit more closely related as far as being, 70 units during the day and 60 units at night, maybe a 10 to 20% difference between AM and PM dosing. And it really should only be different for overnight hypoglycemia. Trying to get patients to take their blood sugars in the middle of the night is difficult. To try to prove to them they don't go low, they feel like they always do. It's a huge barrier to overcome. And CGMs and the Freestyle Libres have been the thing that have kind of overcome and taught a lot of patients they're not as low as what they have felt in the past. So Levemir is also preferred insulin for renal impairment. So anyone on stage 4 and kidney disease should be utilizing Levemir. And again, that is also because of the half-life and the duration of action that it does. It is short, so it doesn't hang around as long. Toujeo and Tresiba actually should not be used. I do have one patient that is just doing well, so you just get afraid to rock that type of boat if it's doing well, but just make sure you're documenting. So when people read your notes, that they know that you should not be using Toujeo and Tresiba in renal impairment, but that Levemir would be the preferred insulin. Also on basal insulins, just bringing up another population is your pregnancy. Levemir is the preferred basal insulin for pregnancy, but if they are on Lantus, they are on Basaglar. I actually have someone right now on Tresiba, and she refused. She would not go back to Levemir. She said she hated it. It was horrible for her sugars. And so I explained to her that the recommendations by the ADA are that we need to make them aware that Levemir is the recommended, but if they are doing well and stable on whatever basal insulin they are presently on and they desire to remain on it, you actually can keep them on the drug. So she's my first one ever. I've had a lot of Lantus through pregnancy, but not necessarily the Toujeo or the Tresiba. And my one lady, she's doing very well on the Tresiba through pregnancy, almost to the point that I'm like, I wonder if I try it more and get some studies. So third type or insulin is the next slide, and this is still long-acting insulin, Novolin or Humlin N. This insulin is cheap, and I hate to say it, but sometimes cheap, you get a little bit of cheaper results, but it's still workable. And unfortunately, in diabetes treatment, I kind of consider it an art. You most of the time don't get to choose what you want, but get told what you have, and now make this patient's diabetes with an A1C of 7, and here's your tools or your, the equipment you have to do it. So do I choose Novolin or Humlin over the counter insulin? No, but when it's needed, and that's what's the only thing your patient can utilize, you absolutely can use it. This also, again, needs to be twice a day dosing. Here's the difference on this. The peaks are in 4 to 14 hours, duration 10 to 24 hours. So it's kind of like Levemir. It does have some wide variety here. And you need to take that in consideration when you're looking at your blood sugars and when they come into you, that why is this happening at this hour of the day? It may not have anything to do with what they're eating, or may have less to do with their eating, and it might have more to do with how they're dosing and when they're dosing. So that's kind of the point in this, is making sure that you realize where the peaks and the durations are for evaluating their blood sugar logs. This can be titrated up, and then this is the only insulin that can be mixed with regular insulin. So none of those other insulins can be mixed in a syringe, and that honestly doesn't really happen anymore in general. That's me showing my age. Next, U500, Humlin N, U500, 5 times as concentrated than 100 unit insulin. This syringe is dialed up. It also comes in vials, but if you prescribe it in vials, please, please, please make sure you're giving them the 500 unit syringes to go with this type of insulin. It used to have just your regular insulin, and we taught them how to draw differently. But now the company actually has 500 unit syringes. They're actually Aqua, and Aqua is kind of Humlin N's U500 symbol or color, so that you know you have the right syringe and you also have the right pen. So you can dial this up to 1,500 units in one pen, a lot of insulin. But this is for patients that are taking over 200 units in a day between basal and bolus insulins. Not many patients, you know, ever kind of come to me on U500. I'm pretty much putting them on U500. So it's not that primary cares can't do it, but it's kind of one of those comfort zones of learning how to work with this insulin. It terrified me when I first started, but it works. It's a good drug for many people that also have a lot of insulin or needle phobias as well. If they're on higher doses and they're twice a day injection and they're 3 times a day for their meals, that's 5 injections a day, and you take that times 7 days a week, and you take that times 30 days in a month, they get really sore and really tired of doing it. So the 500 concentration can be dosed either twice a day or 3 times a day. We talk about dosing prior to meals. Some of these patients have really high insulin resistance, and you try to dose before meals, but the onset, the duration of action is not as long. So it is, I didn't write that on this one. It is anywhere between 8 and 12 hours. So it does not have a duration of action as long. And that's why it sometimes needs the 3 times a day dosing. The 60-40 and the 40-30-30 is the percent basically of how much insulin you would give at one time. So you give more during the day because you're eating. There is peaks to this and onsets of action as well that are much quicker. So the twice a day dosing most of the time is first thing in the morning and then prior to dinner. The 3 times a day dosing is a little bit more tricky. It tends to be 30 minutes prior to breakfast, and then you actually dose about right after lunch, and then you dose again after dinner. So again, it's kind of unusual. You try to get people to back up their and change their lifestyle actually to meet this insulin. And so that's also a complicated aspect to it, is trying to get people to eat differently. You know, they wake up and they want to eat at 12 and 5, and you're asking them now to eat at 8, 2, and 7. So there is a lot of adjustments that need to be made for them also as far as lifestyle whenever you choose to use this insulin as well. Next one, 70-30. It also comes in 50-50. So this is long and short acting insulin. There's basal insulin in it, and there's bolus rapid fast acting. These insulins also get dosed prior to meals and usually twice a day dosing. And so it's prior to breakfast and then prior to dinner. This insulin actually works well. It's cheaper. It works well for the patient that skips a lot of lunches. I actually like it for that. Duration of action is 18 to 24 hours. I do feel it gets closer to the 24 hours, but honestly, this is not a once a day dosing because of the rapid acting. It's always a twice a day dosing. And the 50-50 sometimes is also for people that tend to need or eat a little bit higher carb and basically need more Novolog. So then you would maybe potentially choose that one. Titration also is 1 to 3 days. I tend to use 3 days on this one more because of the regular insulin aspect to it, that people change their diets and do things a little bit differently, aren't always eating the same foods. So to make a change on just a single day blood sugars would be difficult. I tend to use more closer to the 3 days. And then this insulin can also, it's not necessarily dosed 12 hours apart because of the rapid acting insulin in it, but you do need to keep it, because of the 70% being long acting insulin, you need to try to keep it close to the 10 to 11 hours apart. So pay attention to those types of aspects when you're asking your patients. You know, you wonder when their blood sugars are bad. It also has a lot to when do you give your insulin, what time of day, and asking that type of question. So NPH, I think I said already, but it is a cheaper insulin also, which makes it nice too for people that are having cost issues. Moving on, Humalog is our first basal insulin, and then Novolog is the next one. So this is lispro. It comes in 2 concentrations. It's harder to get the 200 unit concentration. I think the big thing we need to worry about on this drug and the other drug is this 15 minutes or immediately before meals. I tell people 15 minutes, both on Novolog and Humalog, and you'll see when I flip over to Novolog, it's a little bit different, but I do teach the same process because of insurance. Insurance, they flip from Novolog to Humalog about every 3 to 6 months. It feels like I'm changing insulins just because the insurance company said so. So teaching them 15 minutes prior to a meal is huge. It also is important with basal insulin to try to bolus before meals because you're trying to get the onset of action for when the food hits there. The people that check their blood sugars after or give it after they eat because they're worried about a low, that you're already allowing them to peak. Their A1C will actually never get as good as what it could be because you're never having insulin there and ready for the food, so that your blood sugar never gets to 250, your blood sugar never gets to 280. So really important. In pediatric world, they teach about giving after they eat, and that has to do with kids not knowing how much they're going to eat, if they're going to be moody, if they're going to like it, that type of thing. As grown adults, I try to say, you know, if you're going to eat that whole piece of pizza, you know, if you're not going to eat it, you know that you're starting dinner preparations, and you know you're going to sit down to dinner in the next 10 minutes. So, you know, count out your carbs and count out your insulin and give your insulin 15 minutes prior to eating. If we could get more patients to do this, you're going to see improvements in blood sugar readings for sure. Duration of action is less than 6 hours, so giving it prior to meals and keeping your meals about 6 hours apart. So a lot of, again, lifestyle changes for the patient that wants to eat, you know, 3 hours from breakfast to lunch, but then they want to wait 6 or 7 hours from lunch to dinner. That does make a little bit difficult and can be reasons for your lows and your highs because of how they eat and then choose to dose this insulin. If you look at Novolog next, which is aspart, this one is 5 to 10 minutes prior to, and this is again package inserts. I think it's easiest just to say the 15 minutes prior to meals. The difference here is duration is action is 3 to 5. I keep this in the back of my head when utilizing this insulin. The difference between Novolog and Humalog is that Humalog says 6 hours. The peak is 1 to 3 hours, and Novolog is, the peak is a half an hour, or sorry, Humalog is a half an hour to 1.5 hours. So we say they're full, and we always use that, but really when you're evaluating their pre-meal blood sugar numbers, you need to pay attention to that aspect, because that could be playing a part in some of your sensitive patients when they switch from one insulin to the other, or when you're trying to figure out why is their blood sugar doing this. Well, maybe it's because the duration of action is only 3 to 5 hours, where Humalog is closer to 6 hours. The next insulin is regular insulin, Humlin R and Novolin N. Again, this is going your basal, cheaper, over-the-counter insulin, obtained at Walmart as well. Concentration is 100 units. This gets dosed 30 minutes prior to meal, so really important that you teach much longer, and that's because the onset can take 30 minutes to an hour. So they really, really, really have to dose. This is not a good insulin that people are dosing after their meals, forget their insulins, and want to dose an hour later. That could be why you're having lows, is because of whenever they're dosing and they forgot. And I thought it's okay. Well, in Humalog, I just forgot. I just gave it right at the end of my meal, and now I'm in regular insulin and I forgot. And now you wonder why you're going low 2 to 4 hours out. It could be because of how they're dosing. Duration of action also is 6 to 12 hours. So you got to watch this, how this can kind of catch up on patients. So many times you have to think of utilizing maybe more at breakfast, less at lunch, and less at dinner, because of the duration of action. So you'll see that, and don't think you can just kind of dose it 6 hours apart, and that each meal has a separate reading towards it, but that potentially your regular insulin is still hanging on at lunchtime, and your lunchtime insulin is still hanging on at dinner. So many times that has to be considered when you're reading your blood sugar logs. Next thing. So this is one thing I was telling as a funny and not so funny, but when patients say insulin doesn't work, a very common, I'm taking 40 units and this insulin doesn't work. Insulin works. Insulin works on every patient. Are there better insulins for certain patients? Absolutely, but insulin works on every patient. So it's the dose that needs to be found to be correct for them. But if a patient say insulin, it doesn't work, there is a few things to also talk about. And this is such, because I had this man that was giving his insulin, upping his insulin, upping his insulin, upping his insulin. He was giving his insulin, he was taking off that first cap, see that big cap where it says keep, and then the next cap says discard. He took off the big cap and felt that he was injecting himself with the next cap on. I'm not quite sure how he didn't feel like fluid running down him, but he was elderly. And just know that there's 2 caps to this. So then the next cap, you discard it. So when you open up the pen, the first cap, and he was having sporadic, erratic blood sugars. It was kind of crazy. And I think it was because he was never taking off that discard needle. And then I think sometimes he actually maybe did and didn't know that he did. I'm not really sure. So just know that there's 2 insulins. When patients say that insulin isn't working, it does work. It's either not the right dose or they're not injecting themselves. And we do have that happens too, where they, just, I don't know, they want to skip insulin, don't want to tell you that they're skipping insulin. So then they say, yeah, I take it all. So really important for them to understand the ramifications of hypoglycemia. And basically this guy then didn't tell me what he did because he was too embarrassed, and then had an extreme hypoglycemic event because he gave the insulin that I had prescribed, but he really wasn't getting. So it was a little hairy-carry. The other thing that patients should be taught in order to prevent all that from happening, and now I talk to my patients actually about it, is making sure they see that little drop of blood come out, or not drop of blood, excuse me, drop of insulin come out of their tip. And then that way they know that the tip is there, they can see the fluid, and they know that it's going into them. So insulin works, it just needs to get into the skin. Here is a titration for basal insulin. I wasn't going to go into bolus because that's really complicated and doesn't have the time frame for this. So the basal insulin, remember ADA guidelines is you want your blood sugar less than 130 if they're under the age of 65. Over the age of 65, you can say less than 140. So teach them that they want to see 80s to 120s. Really important. People say, oh, I have 135, my blood sugars are great. Well, they are good, but the goal is under 130. So titration, not seen sometimes in primary care clinics. I have some people, like nurse practitioners and students that follow me, and a lot of times they aren't given the luxury of titrating, and it's either out of fear of the provider or fear of the patient. So a good instruction is to be really explicit and write it down for the patient, and then following up on your blood sugar logs, but increasing your insulin by X amount. Increasing insulin about a 10% is all you should do. So if they're on 60 units, then increasing by 10% is a small change in insulin. So that's about as much to be kind of safe, and then do another 10%, and then do another 10%. Excuse me. 20% will definitely make a change in a person's blood sugar. So if you don't want to titrate, then many times I'll use 20% of their basal insulin when their blood sugars are not at goal, that I increase it by 20%. But it does scare some people, so sometimes that's not possible. So increasing their insulin 1 unit every 3 to 4 days. And then when you see most blood sugars are at goal, then you hold at this dose. And that's basically what I rate for all my patients. So 5 to 7 days, they're going to look. And if most of those blood sugars, 5 out of 7 days, are less than 130, they're done. They found their new basal insulin dose, and they just ride on that until they show me their next log or they return to their appointments. It's not, basal insulin should not be increased and decreased by the week. But when they do need to do a change because they are not at goal, this is an excellent way to teach your patients how to change their blood sugars slowly over time so they don't feel hypoglycemic even though they're not. Because if someone's blood sugar is fasting in the morning is 230 and you make it 100 the next day, they're going to feel terrible. But if you make it 230 and you increase by 2 units every 3 days, by the time they'll have no hypoglycemia and they'll watch their blood sugars come down, they're going to see goals being met, and it turns out to be a good thing, and they feel like they have a little bit of control. You also have to do educational levels. So I'm not saying every patient can do this. And I have patients that I tell to do it, and then they come back and their insulin isn't changed. And they never sent me a blood sugar log. And then I go back to saying, send me your blood sugar readings every week and I'll take a look at them and I'll make the adjustments. So this can fail, but there's plenty of patients that do very well with this. You must follow up on when they're doing this, because the only error I feel like I see sometimes is patients, forgetting to hold at this dose. They get to a dose and then they'll see their blood sugars go high again. So then they change their insulin dose and then they change it back. And they say, well, you want my blood sugars to be between 80 and 120. So tonight I took 34 and tomorrow I took 32 and the next day I took 36. And you have to teach them that's not what you want done. So fasting blood sugars also are important with doing basal insulin titration. So if a patient cheats, tell them to check it off the next morning. They ate something they normally wouldn't eat the night before. Don't use the next morning's blood sugar. Save your strip and don't even take it. But trying to get about a 10-hour fast. So I strongly encourage most of my patients not to eat after 9 p.m. I think that's a good general rule for diabetics or not diabetics. And then when they wake by 6 or 8 o'clock in the morning, they have that 10-hour fast that you're looking for. So if they don't fast, then I just encourage them to kind of just check that off, and they can't utilize that next morning's sugar. But utilize it to know I ate this and I ate this late and my sugar went really high. So learn from it, but don't utilize it in part of the titration process. And I think one or two more slides. This is from the ADA, and this was a recommendation, so I just gave you the 80 to the 120. But here's the new big thing that we're talking about, and this is the ambulatory glucose profile. And this is with the CGMs. So we're really getting a lot out of, not necessarily taking about A1Cs, but we're talking a lot about in range. And with these Libres and continuous glucose monitors are out here, we talk a lot about target and what is in target. People that are on pumps, we talk about in range. And so this is the new guidelines that they're talking about, and this is to be between 70 and 180. And we want to be up there about 85 to 90% of the time. If you go to the next thing, this is the Libres report, and this is the AGA report that they're talking about in the ADA guidelines. And so you can kind of see how to read it, but it's super nice. It gives you your average glucose, and this is usually over a 2-week period of time that the Libres are actually read. And it also gives you a guesstimated, calculated 2-week A1C. You can see it's 7.6. And then the in range, the target, 70 to 180. Only there 47% of the time on this patient. So a lot of work is to be done, either through adjusting basal insulin and or bolus insulin. And then you see where the high and the very high is over 250s. And then it also gives you those lows. So, you know, anything under 54 is extremely concerning, and urgencies and decreasing of basal and or bolus insulin by 20% when you have hypoglycemia. 10% if you feel like maybe it's mild, maybe they just had like a 65 or a 60 and they weren't really symptomatic and they felt pretty good and it didn't happen until right before they ate breakfast. You know, but at 2-3 o'clock in the morning, they're having 55s. Those require a 20% decrease in basal insulin. So these are the new reports. These are the ones that we're utilizing a lot now and talking a lot more about in range. Not only, you know, A1Cs, the reason we have 6.5 to 7.0 as our goal is to decrease risk of micro and macrovascular complications. So we're also finding that an 85% in range is decreasing those risks of those complications. So we're not going to cure diabetes, but we want to prevent the complications that happen from it. Questions?
Hey everybody, we do have time for questions. Melissa, that was awesome and really excellent. And we got a couple chats in that people were super helpful to hear the titrations and everything like that. That was perfect.
I have a quick question. Thank you. That was excellent.
Thanks.
I'm not a provider or anything, but I heard from the past how to ensure that your patients do inject themselves properly with insulin. I know sometimes some patients themselves and they get bruises over time, and they go back in and they realize they haven't been taking it correctly, even though they think they have been. So I was curious how you would ensure that.
I think it's a part that gets lost a lot by us as providers. I think there's a huge assumption that they are. So when blood sugars and A1Cs aren't moving and going in the wrong direction, I think it starts back to, you know, the basics. And so do I ask them every time? No, but if things aren't going right and they're having problems, you need to start back at the basics and say, you know, and look at their stomach sometimes. You can see, you know, some people have had multiple surgeries and they're injecting near scar sites. You know, they can't be injecting there. The bruising and stuff, they absolutely need to stay away from until it heals. I think people inject too hard. They feel like they really have to jam the needle in. These needles are super tiny and super sharp, and I think people in general just push too hard. But yeah, ensuring is asking, and patience. I mean, that guy taught me a lot. And honestly, I've been a practitioner too long because I forgot that there was that inner cannula needle, but I also had a couple of registered nurses with me that they didn't pick up on it either. So I think the ensuring And we do a lot of teaching. I mean, we don't have patients go out here not knowing how to do injections, at least in our clinic. And I think sometimes we let it to pharmacists to do, and that may or may not be right, because I don't know if they have the time either to do it. So, but I do ask. I ask about, I mean, that's how I found out that they keep the syringe in and they just dial. I never kind of assumed that someone would do it. I just thought they knew to take it out and put it in another site, that you shouldn't inject more than one syringe 80 units if it's a 100-unit concentration. So ensuring is asking.
Thank you so much. Yeah, that communication aspect is really important. Thank you.
I have a question. Tresiba has a long half-life. Does it mean the chances of hypoglycemia will be less compared to Levemir or Lantus?
So we see that. So yes. And that's one of the great things about Toujeo and Tresiba is, yes, less hypoglycemia occurring from it, and less chance of, kind of like I said, that whole twice-a-day dosing on Lantus, Levemir, Basaglar, where you're actually not keeping it 12 hours apart. So you are kind of creating an unequal balance, which could cause some of the reasons for hypoglycemia. But yes, it does flatten the curve and decrease risk of hypoglycememia. Yeah, I love it on my type 1s. I know a lot of my patients get started on Lantus, but I get my type 1s in here and I try to get them over to Toujeo or Tresiba, even if they've been on it for 20 years and they don't want to switch. I'm like, let's try it, because of less risk. And it has to do with the molecular makeup. When I've been to some of their conferences and stuff, they talk about the molecules and how it doesn't, because I'm like, how does it not stack? And it has to do with how the molecules wear off over the time period. I'm not a scientist in that aspect, but yes, less hypoglycemia for sure.
That's super helpful. Thank you. I love how you went over the insurances and stuff, and how obviously that's one of the biggest problems always. And I know this is a very blanket statement, but do you prefer Toujeo and Tresiba to the others if possible?
In my practice, yes. And it mostly has to do with that daily dosing, to ensure our patients are not as compliant as we believe. And you don't want to say, I think they're lying. I think they just want to tell us that they know what to do, but their lifestyle doesn't allow them to do what they know they should do. And that can be because they're forgetful, or it can be because they're super busy, or they fell asleep. And so, yes, I would always pick those doses because of that flexibility, that if you take it at 9 p.m., you can take it at 6 p.m. For my type 1 diabetics that have always dosed in the evening, I think it helps the 20-year-olds that go out in the evening, and Monday through Friday it's fine, but on the weekends it doesn't work. So they can dose at 6 before they go out, and they don't have to worry about going low because they gave it 3 hours early. So it's, in my opinion, it's superior.
Perfect. Well, that's super helpful.
And sometimes we get, like I said, between all of these drugs, we don't always get to pick. So I think when the insurance says this is what you have to use, then think about how this drug is different in durations of action, and when you should, on basal insulins, how should you dose it before, and what is the result might be more about how the patient doses and the duration of action. It's not always what they eat.
Mm-hmm. Everybody, we have time for 1 or 2 more questions if you have them. And Melissa, I wanted to thank you again. It really was an excellent, and I'm super glad that we had you today.
Thank you.
Yeah.
And with once a daily dose, I mean, many of my patients are on Lantus and Levemir. They are on once in a day dose. Okay, I personally prefer giving that in the morning. Okay, just in my mind. Okay, do you have anything preference that when they should take it? I mean, I insist on them that when they can prefer, they can take it, but I insist to take it in the morning.
So that's what's nice about the Toujeo and the Tresiba, is they can pick whatever time of day they want. Like, I'm just like, you can take it at noon, you can take it at 2 in the afternoon. So I like that for that purpose. And classically, Levemir and Lantus single dose is to be dosed at night, but that's classically in the papers and in the handouts. But I too also sometimes like in the morning, because it doesn't have a 24-hour. It doesn't last 24 hours. And Lantus sometimes on patients on higher doses, it just doesn't last 24 hours. So if it's not going to last, then they're not going to go hypoglycemic overnight. But then you have to also think, why are they so high in the morning? And it's because it's not lasting. Maybe it only lasts 21 hours. Maybe it only lasts 22 hours. So then when you're trying to adjust your dosing, it actually can get a little bit harder for you. And sometimes then you cause later hypoglycemia because you raise the dose because they're actually high in the morning, but they're only high because Lantus Levemir didn't last 24 hours. Does that make sense? If you don't have the 24-hour lasting and they give it at night, then you have, Novolog, Humalog that you could use, and you kind of can combat that, dinner time dose that could help. But if they're only on basal insulin and they don't need Humalog, you'll see that they're higher than before they go to bed because it's wearing off at that point. So that's morning dosing you have to consider. It decreases your risk of hypoglycemia because the insulin is wearing off, but you're also potentially compounding a problem because it's not lasting, and your sugars are higher than what they really are compared to if you gave it at night. And sometimes, how do you fix that? Twice a day dosing. If they're over 80 units, they should be on twice a day dosing. But I have some that, because they go high in the morning, but then I start to see issues later in the day, then I'm just like, you have to do twice a day dosing. And then they're doing, 30/30s or 20/20s. So that's where the morning dosing can be tricky. And that's why we say sometimes at night, so that you can see what's happening as it's wearing off, or you can use Novolog, Humalog for lunches and dinners as that Lantus Levemir is wearing off. I don't think there's a wrong answer in it, but you just have to think about what you're doing, what could be the outcomes because of that choice.
So if you are dosing Levemir 42 units in the morning and you're getting more of the higher numbers for fasting throughout this period, would you just decrease and just split that dose up equally and see how they do and then reevaluate? Or
Correct.
how would you manage that?
I would try, if they were getting higher once a day dosing, 42 units in the morning, and you're getting some higher readings in the morning, but they're good for the rest of the day, I would try twice a day dosing. I'd put it 24/24. Especially if it was Levemir. Especially if it's Levemir.
Okay.
Levemir never lasts 24 hours.
Right.
Well, thank you.
Remember with actually Lantus and the twice a day dosing too, goes back to that statement. Remember that there's no peak. And if there's no peak, the reason you should not have like 40 units in the morning and 20 units at night, because there's no peak. So you want to try to keep those doses even. And if they're having nighttime hypoglycemia, then you have to fix it by lowering the overall dose, both doses. And then if they're getting high during the day, the answer is not to raise that more. The answer is put basal insulin or bolus insulin, because they're starting to go high during the day, proving that they can't be pushed down anymore. And now you have to start mealtime insulin. So that's why those doses really shouldn't be too far off. I'm not saying they can't be a little bit, but that's why they shouldn't, because there's no peak.
Okay, well, I have one last question then. Let's say you've got this patient on the Levemir 42. How do you, and it's I think he's a 78-year-old male, and his numbers are around 200s. And I think Tresiba or Toujeo would be a great option. What would you recommend for, like, how would you switch them? Where would you start?
Good. I should have counted that in my thing. So if they're running 200, fasting sugars, I go 1-to-1 right away. I just go 1-to-1 because they're high. If it's someone that's actually pretty well controlled, but who really changes a well-controlled person? Not me. But if they are well controlled and their fasting sugars say they're always like 130, 150, not too bad, but you're going to try a new insulin, you would actually want to drop by about 20%. So drop them from 42 units, about 8 units, and then titrate them back up as they need it. They tend to be about the same dose, but not always.
Okay, thank you.
You're welcome.
Well, thank you all. Thank you, Melissa, of course, and thank you everybody for being so engaging and interactive. That really helps. So our next session is on the 24th of this month. It'll be at noon. Melissa is covering that session as well, but we have decided to, for a lot of our sessions, Mitra and I have decided that they're going to be case focused. So in order to keep that session going, we really need cases to come in. The last several of months have been outrageously tough on everybody. I know it's been hard to get cases in, but Mitra and I are here to help with those submissions. And we just want to make sure that we're still following the right path. If you guys have patients that have different needs, we want to make sure we're giving you didactics that showcase that. So we're hoping to get 2 or 3 cases for that session. But even with 1 case, we'll continue that session. So that's what it's going to be built around. If you have coworkers or anything who've been asking you questions, just invite them. They can totally come and present their own case. And if they can't be here but want to submit a case, we can present it for them. That's not a problem either. So I just wanted to let everybody know that. And that's it. And everybody have a wonderful week.
Thank you.
Thank you.